Hello and welcome to today's webinar. My name is Joseph Krieger, and today we're to be discussing the clinical applications of microfragmented adipose-derived biologics, and we're pleased to have experts in these topics. David Angeloni. David is an industry expert with a large body of evidence in commercialization in understanding the science biochemistry of adipose-derived biologics. David has been responsible for commercializing technology as well as teaching the biochemistry and clinical applications of adipose-derived biologics, and Brian M. Kenny, MD, who's a board-certified plastic surgeon. He'll be talking about the clinical aspects in cosmetic dermatology, and he's the past chairman and board of trustees of the American Society of Plastic Surgery. So, gentlemen, welcome to Boston BioLife, and we're looking forward to hearing all about adipose-derived biologics. Thank you.
Thank you for joining us. In this discussion, we have the privilege and honor of having Dr. Brian Kenny, plastic surgeon out of Beverly Hills, joining us to discuss the science and technology behind IntelliFat. So, in getting going on why we do what we do regarding our products involving fat collection and fat transfer, we really try to look at it from the client's perspective as well as the patient's perspective. So everything that we do, we try to deliver in a method in which is going to be efficacious, safe, and cost effective. And so we want to try to provide these products to our clients, which are plastic surgeons, cosmetic surgeons, and even orthopedic and pain management physicians, in a method that makes sense and is not trying to push a gimmick or anything that is just overly complex. So we like to collaborate with our physicians, get feedback regarding patient experience, and put out products in which just make sense. So you can see here, leadership at Cellmix really has a passion for providing products that are safe, efficacious, as I mentioned, and even those that we use on our friends and family. So really our focus, as I mentioned, is fat. This is autologous adipose. We don't carry any allogeneic products currently. We used to carry products that were amnion based, but we got out of that to really focus on fat. So all of our products meet the compliance with what's called Section 361 of the Public Health and Service Act, which 21 CFR 1271 within the Federal Code of Regulations is enforced through, which what the FDA uses. So everything is compliant that we use. All of our products meet either ISO or CE requirements, and we do have a really good quality control, quality assurance program to assure that everything that we do is safe and effective. So in discussing a bit about our products, obviously we're going to be talking about IntelliFat, but we do have other products that we make within the fat grafting world regarding canisters for fat transfer, cannulas, liposuction tubing, a great modality called Aquacell, which allows you to infiltrate, aspirate, and re-inject adipose for large volume transfers. And LipoLoop is the tubing that's used during that type of procedure for a breast enhancement or a Brazilian butt lift. So we do carry a lot of other products outside of just single-use kits like IntelliFat. So in getting into this field of medicine, I had the experience of using adipose in order to create 3D skin grafts. Because we like to use the fibroblast that were derived from that we would wind up digesting out in order to make these 3D skin grafts in a collagen matrix. So in experiencing that, we would get donated tissue all the time, and sometimes there'd be a lot of great cells present, and sometimes there wouldn't. And it wasn't too long after that in which, doctors like Dr. Yoshimura started really looking into what's in fat, and even all the way back to the publication in UCLA when they discovered actually stem cells in fat. That the makeup of fat not only consists of adipocytes, but a lot of other great cells that can be used for regenerative purposes. They kind of like your adipose or subcutaneous tissue is very unique in which it lies, in between the skin and in between your muscles, so that you actually have a storehouse of a lot of regenerative cells that can migrate up to the skin in case of injury or migrate down to the muscle in case of injury. So it's like it creates a great environment in order for these cells to kind of lie dormant and wait to react to certain chemokine, cytokine, or even traumatic injury related um, scenarios. So in the makeup, even though almost 80% of the volume of your fat on average will be an adipocyte because they're one of the largest cells in the body by volume, only about, according to Yoshimura, only 16% of them will be an adipocyte, maybe 20 at most. The rest will be progenitor cells, endothelial cells, fibroblasts, epithelial cells, parasites, um, leukocytes or erythrocytes, obviously too, or white blood cells. So it's a very diverse, heterogeneous population of cells. So where a lot of these cells lie along is the arterial and venous wall. And here's kind of a breakdown of some artwork on how they detail the lumen of the inside of an artery or vein, and how all of these cells play a role in all not only local but systemic cell communication mechanisms when it comes to obviously your metabolism, etc. So here are a few other shots. Here's an H&E stain on the right. You can see this is a vein in which you have all the epithelial cells surrounded by the adipose, and in and around there will be macrophages, different types of obviously other leukocytes, pericytes, which are thought to be MSCs, and other type of regenerative cells. And here are some markers in which you can actually see these cells. CD90 is a great marker for a fibroblast progenitor. CD146 is a great marker for a parasite. As you can see here, this is all lit up around these arterial and venous walls. This is using fluorescence in situ hybridization. The DAPI stain you see is blue is actually staining the nuclei of the cells. It's a nuclear stain. CD73 is also a great marker for a mesenchymal lineage connective tissue. It could be a fibroblast progenitor, an epithelial progenitor, or possibly even a parasite will express CD73. And so when we're talking about using fat for regenerative purposes, not just in aesthetics, but just across the board in soft tissue regeneration, we're born with a lot of these stem cells, obviously, and as we age and we die, we start losing these amount of cells. It's part of what the theory of the limit is, as being the max potential age of being about 130 years old. And you can only these stem cells can only go through so many doublings or reproductions until they lose their stemness. They become senescent. So as a newborn, according to several publications and looking at the amount of stem cells in bone marrow, you can start with a lot, and as you trail off, as we age, we slowly lose a lot of these cells dramatically. And within fat, that scale is a lot higher and less severe than it is within your bone marrow, according to many publications. So you have only 600 as a newborn per 1 million cells in your bone marrow, where you have as much as 200,000. And so you can see here that your fat is a very great storehouse of regenerative cells. Now, obviously, your stem cells within your bone marrow can have certain unique characteristics in which you may want for regenerative purposes over fat. But in general, when it comes to soft tissue regeneration or repair, your fat certainly does have an advantage from a lot of certain standpoints. So in breaking down some of these numbers, you can see that adipose on average will contain about 5 to 10 million cells per cc or per milliliter, in which about 50 to 80%, and this is using Yoshimura's data and some other a lot of other publications data, will be stromal SVF, the stromal vascular cells. So of those cells that are stromal vascular cells, it's estimated 1 to 10% of them are a stem cell. And so with the mean average of about 3%. So that means extrapolating that, you're going to have somewhere between 5,000 to as much as 200,000 adipose-derived stem cells per mil of adipose. And looking at Pitteger's publication, it's pretty uniform. You're looking at about 6 million cells per milliliter, of which only 0.001 to 0.01 are a stem or progenitor cell. which is only 60 to about 600 per milliliter. So obviously you see the unique advantages from an autologous cell therapy or regenerative standpoint, that your fat does have some unique advantages in numbers alone. Um, when you're looking at PRP in peripheral blood, you're lucky to have 1 in 400,000 or 1 in 2 million being an MSC or a mesenchymal type of stem cell that is circulating your peripheral blood. So PRP really isn't, like some doctors will miscommunicate on their websites, that they do stem cell therapy and that PRP is a type of stem cell therapy, when it's really not. According to Dufresne, the impact of age in human adipose stem cells for bone tissue engineering, it published in Cell Transplant, has very unique and several advantages. You guys can read this publication if you want to in your own time. I'm going to continue to move forward. So we're going to, and talking about harvesting adipose, there can be a lot of weak links when you're looking at doing or performing autologous cell therapy in clinic. All it takes is one weak link, one missed process, and you can damage your tissue in which you're planning to transfer. So that's with your PRP, with your bone marrow, with your adipose, and obviously with a lot of other type of grafts in which a doctor may be performing. So the protocol does matter. So in just starting with actually the harvesting, your tumescent fluid actually could be, if it's not pH balanced, can be harmful to the cells. When we grow cells in tissue culture, we try to keep the pH above 6.4. But if you're using lidocaine and epinephrine, these are pHs which, in order to keep the protein stable, will be in the 3 to 4 range. So it's important that you balance it with sodium bicarbonate, even for a comfort level with an awake patient. Lactated ringers does not contain anything that can actually buffer pH. You can go ahead and look that up and Google that if you don't believe me. Lactate is metabolized into bicarbonate in the liver. So when you're actually when it's within a subcutaneous tissue, it's not going to get balanced or buffered. And if it does, through cell metabolism, it's going to take a very long time. Pardon me. The harvesting cannula is also very important. So we try to avoid sharp edges that cause trauma or tered septae within the fat aspirate. This This is important, but not as important when we're just looking at stromal and vascular cells. But when it comes to the fat itself, the adipocytes, this can be very important when it comes to viability, especially when it comes to if you're using a mechanical modality or not. So if you're using a rasp edge type, like a cannula, it looks like kind of like a cheese grater with a rasp edge, then you have aggressive reciprocation, you're of course going to be damaging a lot of cells during that harvesting. This can also lead to, if you're grabbing a lot of septae, lead to blockage when transferring in smaller applications when you're trying to get through an 18, 20, 22 gauge needle or cannula. Negative pressure can also be the enemy. I'll get into that in a little bit on a slide. So we try to stay above 0.4 atmospheres, which is 405.3 millibar. Believe it or not, it doesn't matter what the size of the syringe is. 10 cc's of negative pressure at sea level will create about 0.4 atmospheres. Gravity separation, decanting, and infrenating. This is somewhat important. You don't have to always do this, but we try to avoid centrifugation to remove too much fluid from the adipose graft itself, because the cells can only survive via nutrient diffusion until angiogenesis kicks in. So you need to have a little bit of a saline buffer. If the fat graft is too dry, it's also going to be too difficult, and you're going to have to apply more pressure in order to get it through the finer or tiny lumen of a syringe, which is only 2 millimeters, or even tinier if you're looking at using an 18 gauge or less needle. You want to try to transfer also immediately. Adhere to about a 4-hour window. I've seen it where adipocytes will start dying under the microscope in less than 4 hours easily. So they're a very fragile cell on top of being the largest cell in the body. So when harvesting adipose, size does matter, and I get all this and give credit to Dr. Yoshimura, who published this information almost 10 years ago now, or maybe 8 to 12 years ago. He talks about 3 zones in which a fat graft will survive. There's the surviving zone, in which all cells can survive via nutrient diffusion until angiogenesis kicks in. Then there's the regenerating zone, in which just the adipose-derived regenerative cells or the pre-adipocytes, which have the ability to turn into an adipocyte once a adipocyte is close to it, goes through apoptosis, and all these stromal and vascular cells can survive because they're a little more robust on the adipocytes. Then you have the necrotic zone. Most of these cells will die, they won't survive, except for the very strong MSCs, which I've seen can last quite a long time at very hypoxic environments and even at room temperature, believe it or not. So those cells can survive even into a necrotic zone, I believe, under certain conditions. So, but very few will survive. This is a under the microscope what about a 1.5 by 1 millimeter size fat graft looks like, and you can see the adipocytes vary in size. They can be as large as about 110 micrometers to as small as about 40 in diameter. So when we're doing fat grafting, then we want to try to achieve nothing larger than a 2, maybe 3 at most millimeter size cluster for the large volume, and preferably 0.5 to 1 millimeter for small volume facial applications. Unless you look at some publications by some of the top plastic surgeons where they would like to try to get larger structural fat into the buccal fat pad, which Dr. Kenny, if he chooses to, can elaborate on later. And so I ask a lot of doctors who are interested in getting into fat grafting or already been performing fat grafting for a while. Do you know what's actually in your fat graft? Have you taken a look at what it'll look like once it settles out without any further manipulation once you harvest or after you go through further processing or resizing? And so this is an image of the cell mix Super G Micro harvested at 0.4 atmospheres by Dr. Stephen Cohen in San Diego. As you can see, you don't have many, and this is with the same patient, by the way. You don't see many lipid droplets forming. You don't have really a great lipid layer on top. This is after centrifugation at very low G for a short period of time. This is what you'd see with the tulip harvester with their protocols which they follow, and they lock at a greater negative pressure than that 10 cc's. That's why we have a very specific syringe that we use to harvest it, called the vac lock. It allows you to lock at 5, 10, and 15, whatever you choose to at a time versus just one, all the way back or half and full setting. And Dr. Kinney can show that later. But you can see the fat droplets starting to form, and this is from the same patient, all within a very short period of time, each other, left side, left flank, right flank, I believe. And so obviously this method was a little more traumatic in harvesting the adipose than following our protocol with using our Super G Micro. And then once this tissue was actually taken through the nanofat process, we centrifuged it, and you can take a look at what you see here. You see just a saline layer, very little saline layer. You see a bunch of proteins, probably carbohydrates, extracellular matrix, all here, and then all lipids. So the final product, actually, what's the more important part, you don't want all these lipids, it's what's right in here. So all the adipocytes were obviously lysed, damaged through the whole harvest and processing of doing the nanofat process, even though there may be still viable cells that are alive that have value or can grow in tissue culture within this layer right around the 5 cc mark. And so this is why we came up taking all of these ideas into account in IntelliFat. We start with having a great cannula for harvesting millifat, which is 1 to 1.5 millimeter size clusters. So we have our Super G Milli here, which is a great cannula for doing that with negative pressure syringe. It is 24 holes, or excuse me, 21 holes with about a 1.25 size aperture. You have your patented Super G Micro cannula here. That's 300 holes with 500 microns in size. I'll talk about this later in another slide, and so will Dr. Kinney. It's a very unique cannula that allows you to directly harvest microfat. Every transfer cannulas, this is a 19 gauge by 5 centimeter microfacial cannula, and then you have a 12 by 18 for anything if you want to do hand applications or anything in which you need more reach around the face. What's really unique about IntelliFat, though, is this filtration or resizing system. So if you struggle with the Super G Micro, or you happen to want a more cell-rich micronized fat graft, you would harvest millifat, and then you can resize this, and we'll show how this is done through this resizer, which will break it down into 500 micron size particles or less. It will damage some of the adipocytes, yes, but you will have a very rich graft full of stromal and vascular cells that we like to term as SVT or stromal vascular tissue. You have two filters in which you can also clean up the fat graft in case you have too much blood. One for the microfat, or which it also would be used for the SVT. It's a finer filter, and then you have a milli filter, which is for the fat they initially harvest with this Super G milli. We also, for your convenience, provide two female-to-female lures, two syringe caps, and what we call stroma stamp. This is an idea from one of our plastic surgeons to include it in our aesthetic kit, because you can take this micronized SVT, add a little bit of platelet pore plasma to it or even saline to it, and stamp it into the patient's face, being able to delegate that to whatever staff you want to, for an added benefit of stimulating the epidermis if you're doing any facial treatments or whatever during your fat grafting procedure. So I'm going to show a short video. I hope it works. This is for use within orthopedics. You can't hear the video, unfortunately, but this is showing a soccer player hurting their knee and them going into the clinic and wanting to get, instead of having to go through a more invasive procedure, try to do it, regenerate the joint naturally. So the kit will allow you to TMS. We're going to wait for the epinephrine and lidocaine to work about 10 minutes, 15 minutes max. And we're going to only lock to 10 cc's as we harvest to make sure that we're not damaging the cells. Now again, this is more for the adipocytes. You can pull it back to 15 cc's if you only care about the stromal and vascular cells and not the adipocytes. It's going to attach the milli filter. It's going to leave all the structural tissue in the syringe, get rid of the waste. And then within the syringe, stays closed, you can add saline and wash it. You would flip the filter then around to the other side and push off that waste again, because after you use it on one side, you can turn it around and use it on the other side. You can continue to rotate it. And now they drew it into a 10 cc syringe. You want to use a 10 cc syringe to avoid too much pressure and pass it back and forth to break it down. And then from there, it's ready to go. You can clean it up further using the microfilter as well to get it to where the product almost looks off-white instead of yellow like the Adipose. So, in talking about stromal vascular tissue, I like to define it as the supporting cellular matrix infrastructure within the adipose. This includes endothelial cells, fibroblasts, parasites, smooth muscle cells, mesenchymal cells, leukocytes, and lymphocytes. So it is a microstructural tissue that's 200 to 500 microns in size. It's considered minimally manipulated by the FDA. I think it's superior to nanofat because it has more viability. And you still have some of the adipocytes that are still present and viable, which can provide still a valuable function even in orthopedics. So in talking about just sheer numbers, an SVF, a collagenase process, can only yield about 20% of the total stromal and vascular cells in adipose tissue. This can be slightly improved upon if you resize the tissue a bit as well and have a ideal digestion protocol, maybe 30%, but on average, you're looking at 10 to 20%. And so when you look at the numbers, 50 cc's of digested adipose is going to equate to about 10 cc's of SVT. Again, this is estimated, but you're still going to have a lot more cells per capita within SVT than you would after harvesting, digesting, and then resuspending your stromal vascular fraction from a collagenase process. It's proven by Vincenzi and a few other publications that this microstructural tissue has a superior colony-forming unit fibroblast growth curve, an SVF. It's theorized it's because when you have, instead of a single cell suspension, where the cell is struggling to in order to get a colony going, you'll have these little micro colonies, in which it's easier for these cells to go ahead and grow into colonies themselves. So the average total nucleated count per milliliter in our data was 1.73 million, with about a 51% viability after the harvesting, resizing, and shipping for a day to where we have this tested. The CFU per milliliter for after 10 day was 16,600 with 1% frequency from the total nucleated cell count, which is very good compared to any competition like lipogems. When I bounce this off of a lot of our regenerative doctors. So in the processing, we already talked about we want to achieve 1 millimeter adipose clusters. We want to remove the blood component with the millifilter. We will then resize, clean up any extra lipids, and then we can go ahead and transfer through as fine as a 25 to 27 gauge needle. I've seen you can force it through a 30 gauge, but again, we're trying to avoid pressure and damage to the cells. The larger gauge you're comfortable with working with, it's the better for these cells. And in this image here, this is the inside schematic of what the Diamond-Cut micronizer looks like. It is a lattice with edges that allows less pressure to be put on the tissue as you're passing back and forth versus a wire mesh like a lot of other companies will use, like Tulip, not to bash on them, or even a stainless steel perforated disc like what Ranfac uses and some of the other Korean products will have, where they take a stainless steel disc and they punch a certain hole pattern or any other pattern for that matter through it, which still leaves a lot of not open space. The more open space you can have, the greater the fluid dynamics is, the better. So we felt that this design is ideal for breaking down the fat. It's and increasing viability. So on the colony forming unit assay that I quoted, this was the control, and you can see here that on the right here, the IntelliFat taken through the SVT process was far greater than a prototype Tulip, and I think another process that we were using with a mechanical breakdown. So it worked extremely well. That's why we went forward with going to manufacturing with it. And so I talked about pressure through syringes. Pressure is really the enemy. We want to try to avoid both positive and negative pressure. So cells can burst when you exceed about a half an atmosphere. This only equates to about 8 cc. So you can get down to, like I said, 0.4 atmospheres is what we'll set an aspiration pump for large volume fat transfer. Viability is still fine, but now cells can start to burst at even 0.5. SVF cells are more robust, as I mentioned, than adipocytes, mainly due to its size. And here's a breakdown of pressure per milliliter as you increase the negative pressure within a certain space. So again, 10 cc's is that sweet spot where you're about 400 millimeters of HD mercury. Positive pressure. Obviously, there's many variables when it comes to creating positive pressure as you're pushing through a syringe. The graft cluster diameter, the viscosity of the graft, how much the saline percentage within your fat graft, and the lumen diameter of the syringe and cannula or needle. So here's a good diagram that I found when modeling basics variables when it comes to pressure pushing through the syringe and how the hub, which leads into the inner lumen into 2 millimeters, can really put a lot of pressure from the applied force. That's why a lot of doctors like to use 1 cc syringes when transferring. It's an easier transfer and less pressure. And then obviously as it goes through the final lumen size of the cannula, that's condensed even further from 2. So again, making sure you have at least 30% saline and the appropriate graft cluster size, you can avoid the positive pressure pitfalls that a lot of doctors may unfortunately go through when it comes to fat grafting. So IntelliFat versus NanoFat, when we used or when we performed our studies to validate IntelliFat, we use Tulip's NanoFat. It's been a standard. We know that it does get results on a clinical level to a certain experience or a certain level. It's been published, obviously. We just felt that we wanted to go out and possibly create a better protocol, and something that's unique and a little bit different, and may have different applications as our doctors start to use it more. So the first thing that we noticed was just lipid content in general after the process. You can see here, where you ever see a dramatic amount of white or black, those are lipids. As you can see here, we have a lot of free floating adipocytes here. We don't have a tremendous amount of lipids present, and so our lipid content, as you can see here, is lipid droplet, lipid droplet, lipid droplet. But it's just everywhere. So we do know through our process with the filtration and all, using the milli and the microfilters, we can remove a lot of the lipids that may be present, as well as what we're trying to accomplish is not insulting those adipocytes as much, especially important, obviously, for those um, aesthetic applications where you may want volume and your adipocytes alive, but equally as important in orthopedics, because you don't want too many lipids, because they're inflammatory within the joint space. And so IntelliFat versus lipogems. Lipogems is great. It's just a little um, burdensome, according to a lot of physicians, as well as expensive. But we can directly, through harvesting with our Super G Micro, get the same size fat clusters with a very similar viability without having to take it through a complex process. So we just created a different mousetrap. Basically, we feel saves more time. Obviously, would save you more money as well. So we feel that we can create a very similar product to them, just in a different way. So in review of using IntelliFat, it's a streamlined point of care processing that takes, depending upon your procedure, at least the harvesting, processing, and before transfer, 30 to 45 minutes max. There isn't centrifugation required. That's only filtration, so you're saving time and money. There aren't any enzymes involved or any capital equipment if you're looking to use it for regenerative purposes. As I mentioned, stromal vascular tissue is much more cell rich. You can get more cells per capita out of it than you can in harvesting fat and trying to digest those cells out. And so we also know that SVT, according to the publications, has a higher regenerative potential than SVF and nanofat and other emulsified centrifugation methods. We just feel that more parasites and MSCs that are within the vascular niche will have more value. They'll be able to pull off or migrate off and do their job once they're transferred into the new grafted region. And so IntelliFat mechanical resizing and filtering is compliant also with the FDA guidance and appropriate medical procedures. We'll be working on getting CE compliance and approval as well, since all of our biocompatibility and sensitivity testing and all that is all done ISO certified. Here's some of the publications in which I referenced. You can feel free to look those up at your leisure and pause this right now if you're viewing this recording. And without further ado, I'd like to introduce you to my good colleague and friend, Dr. Brian Kinney, who's a clinical associate professor of medicine at USC, where I'm my alum, past president of the Plastic Surgery Education Foundation, and he is a chairman of the board of trustees, and he's spoken all over the world, and one of the most respected people in the industry, and a very respected person. From myself, from a standpoint, he is a mentor of mine. So, Brian, take it away.
Thank you very much. So what I need to do is just share my webcam and we'll go forward, share my screen. So let's go here and let's go to a different screen, just a second, and we'll be ready to go. There we go. So we should be seeing my screen now with my slides.
Yep.
So I'm going to talk about some clinical applications specifically in the world of aesthetics. Now, I'm one of the co-founders of the International Society for Plastic Regenerative Surgery, but in this particular case today, we're going to discuss aesthetic uses. In addition, I've been involved in a number of startup companies, and I'm a patent holder and have done a number of other things in the organized world of plastic surgery and in the entrepreneurial side. I currently am a associate editor of the Blue Journal, or the Aesthetic Plastic Surgery Journal, and the Archives of Plastic Surgery of Korea. And I've presented over the years many places, many countries, done live surgery, live clinical demonstrations, and had the opportunity to perform a number of interviews. And my background includes being in the Harvard MIT Health Sciences and Technology program. In addition, I have a bachelor's and a master's in engineering from MIT, and I've certainly had a number of publications. So what I'd like to do in the next few minutes is walk through how I use it. David's covered in a very excellent fashion some of the basic science, some of the rationale for the procedure, and some of the supporting data. And so I've been doing fat injection for a long time, and I've tried a number of commercially available systems. And of course, now with the way the FDA has approached or looked at or considered fat grafting, enzymatic and centrifugation techniques not only are capital equipment, but also run counter to some of the current FDA thinking about what constitutes minimally processed tissue. And so the IntelliFat program, which I've been involved in helping to develop, is fairly straightforward, and I'm going to walk you through how it's pretty easy to use, and it has a shorter processing time. There are fewer steps, and it's been proven by some of the data David showed with colony forming units and fibroblast counts that it yields excellent viable tissues. And we can inject through small syringes, and we can have a high quality final product. So we're going to go through some patient collection, consent protocols, supplies, workflow, and setup. And we talked earlier about patients that are older, have fewer stem cells. We're aware of that, but we're lucky because fat has so many stem cells that if we have to, we can use larger volumes of injectate. And I prefer fat certainly over PRP, where there's just a fraction of the number of stem cells. And we can use this for aging-related loss of soft tissue mass, which is what we have in the face, and then traumatic defects as well as aesthetic contouring irregularities. And even if there's 2 centimeters or less of body fat in areas where we like to harvest, say the periumbilical region or the inner thigh, we can still harvest enough tissue to be able to have adequate volume for the face. And generally we can do the upper gluteal area, we can do the flank, and the abdomen is one of our preferred areas. And sometimes you may have to harvest from multiple sites if there's not enough fat. And the fat closer to the surface tends to be best. It tends to be fresher and perhaps, clinically speaking, more metabolically active. Millifat is the 1.5 to 1 millimeter, and we call microfat the 1 to 0.6. And then the stromovascular tissue, or SVT, is the less than 500 micrometers. And you know, we use the term nano, and I have a saying which is if I can see it, it's not nano. You can actually see micro, hundreds of micrometers, but nano you cannot see. Oftentimes we'll do a touch-up treatment at 3 months for contouring or additional volume. And then the question of whether we use PRP and what growth factors may be in there, even though it's not the stem cells themselves, so we have to consider that even though PRP is popularly clinically used, the science is on a different footing. And then we can potentially, with level 5 evidence, add PRP. And we don't need a lot of tools. This shows larger syringes, and it also shows the vac lock. And if you look carefully in the vac lock, there's little ridges on the white part of the shaft of the piston, and these are where you can do a half twist and lock against a stop that will give us our 10 cc per time aspiration pressure at 0.4 atmospheres. And David's already mentioned about using bicarb to buffer the saline because of the pH, and the lidocaine and the epinephrine will be injurious or compromising to the harvested cells. And we use about a 3-to-1 ratio. When we're infiltrating, it doesn't matter because you're infiltrating a tumescent fluid, and you can use larger syringes. I find 30 cc's gives you better control because of the large piston in the 60 means you're not as precise in your injections. And in the face, we often use 1 cc syringes for injection. In the body, for contouring defects, we can use 10 cc. And we don't usually use an 11 scalpel. Most of the time, we'll use a 16 or an 18 gauge needle to gain access. And you can even dilate a little bit. But that way, often we don't use sutures to close those access sites. We use sterile drapes. We consider it a local procedure, and we can gown up, but you actually don't have to gown up in the aesthetic world on the face. If you're sterile with a mask and with gloves on, you can do this similar to the kind of care you would use with a facial injectable procedure. And our data shows that rate of infection is negligible. After hundreds of these, we don't yet have a wound infection, so we don't consider it a big problem. We usually use betadine for skin prep. You can certainly use chlorhexidine. The only reason I use betadine is because I can see exactly where I prepped when I'm doing a local procedure, and it just gives me a demarcation. Wound dressings, usually we'll use Steri-Strips. Some people like a Tegaderm. You can use sterile gauze, and you rarely need a 5/0 suture. I don't really worry about it too much. You could use a gentle compression. But of course, too much compression could be injurious to the freshly seeded grafts. And we use sterile gloves and a surgical mask. Optionally, you can use the MAF gun. That stands for micro autologous fat transfer. I certainly like it, and I will show you this. It gives you precision injection of grafts with a linear retrograde pattern under minimal pressure, in keeping with our desire to have obey Yoshimura limits on adjacent capillaries, as well as minimal pressure and injury. David had already mentioned, maybe 10 minutes for the tumescent fluid to set up and get the epinephrine effect. So we have your assistants prepare this, and then we draw and start PRP preparation if you're going to do it, which generally I don't. And then we have everything on our Mayo stand, and then we wait for it to set up. And then if you need to, you can go see another patient and come back. And this is the kit. This is the particular one that's for aesthetics. There's multiple kits. We've talked about the diamond cut resizer. That's for the small fragments and the small cells. And then the micro, and then the milli. And again, the milli is maybe 1 millimeter to 1.5 millimeters. And the Super G milli and Super G micro cannulas are something I'm going to cover in more detail in a minute. The stroma stamp is something that one of your nurses or PAs can do. It's a little tiny spring-loaded canister of about a couple of mLs with it's like micro needling. And what it does is micro inject small amounts into the epidermis to stimulate skin. And then this is the regenerative kit that doesn't include those small cannulas. And if you don't want to invest in capital equipment, this can be on a per case basis, or you can buy packets of 5 or 10 in addition. Well, here's a look at the millifat cannula, and you can see those 21 holes, 2.5 millimeter diameters, and the edges are smooth, and the 1.2 millimeter apertures for harvesting. And some of the larger cells could get through, but in general, it's given you an upper limit on what kind of cells can come through. And it's 15 centimeters long, so plenty enough length. And the microfat cannula, this is my favorite for the face. And if you look at it, there are 500 micrometer holes, 300 of these holes. And these are made by laser. And if you look at them under high magnification, the edges are smooth and polished. So you're not creating a lot of cellular debris. You're harvesting cells with upper limits sizes. So you're doing pre-filtration in essence. And you can use it for your infiltration of saline as well. So the procedure, the workflow is you decide what kind of sites you want for harvesting, and you decide what kind of cannulas you want. And say in the eyelid, I'll go through this in detail in a minute. In the tear trough area, you may have very fine cells all the way up to jawline, where you may have structural fat. You clean and prep that skin, apply your local anesthetic, and usually a 16 gauge needle puncture will be enough. And that way, you don't need to really use sutures to close, and you don't often need that 11 blade. And then you attach your infiltrating cannula to the syringe with your tumescent fluid, and you go in perpendicular initially and then rotate 90 degrees to pass the cannula parallel to the skin as you advance for infusion. We infiltrate slowly to get a dissection, and then we fan over a large area to get the harvest area, and just don't dump that tumescent solution in one location. So we go back and forth with fanning and use the full length of the cannula. One of the things about the local anesthetic is that if you get near the edge of the zone and when you harvest, you go the rapid back and forth motion, maybe at 1 hertz. If you pass point, patients will feel a little sensation, and it's just best to minimize that so that it doesn't happen. So you want to go a slow, gentle gliding motion, cover the entire area both during infiltration and during harvesting, and then wait for that vasoconstriction, which takes 15 to 20 minutes. Of course, the anesthetic will take place much more rapidly in comparison. So we attach to the VacLock syringe, you saw it in the previous picture, and you insert the cannula without suction, and you can pre-tunnel to create a number of pathways. And what this does is help you that when you want to harvest, you're not doing it under high pressure, and you do it until you don't feel fibrous, so that you're not having to break down things at the same time. And then when you do that 10 cc and lock it, you just don't want to go higher because of the pressure phenomenon and the injury to cells. And you may need 20 or 30 cc's for the face. You may need 5 or 10 cc's for each hand. In the old days, my good friend, Dr. Sid Coleman, he and I have known each other since the beginning of his fat grafting experience. He used to put in large volumes, but with the higher yields now, you don't need to do that. And then you can close up those wounds usually with a steri-strip and maybe a gauze on top. And then you can gravity decant. We talked about this earlier. It's not necessary to use centrifuge, and then you separate, and then you'll use a milli or a micro filter depending upon what you want, and micronize the fat for SVT, and you'll have less free lipids if you use that micronizer filter for that. And then you can inject into the final product into the syringes, from the larger syringes to the smaller. In the body contouring, I'll use 3 cc syringes, but in the face, it's almost always 1, so we line up a whole number of these. And this is what the injection tray may look like with your syringes before you're transferring into smaller ones, or if you're just using in the body. So I like the micro-autologous fat gun. I don't have any financial interest in it. And you do need to know a detailed knowledge of facial anatomy. In the temple, you may use 3 to 5 cc's of structural fat per side. In the forehead, it may be 1 to 3 cc's per side. And in the canthus and the periorbitum, it may be 0.2 to 2 cc's per side. And then with the jawline or the chin, you could use up to 10 if you're going all the way around the angle of the mandible, all the way down the mandible and towards the mentum. And then the nasolabial area and periauricular anterior, posterior cheek, you could be using up to 5 cc's in designated areas. The 10 ml MAF gun is also used, but right now we're going to focus more on the face. Again, it is extremely critical to know the regional anatomy, and you can break up a little with the sub-Q with larger 16 gauge needles or some pre-dissection. But the gluteus is a highly dangerous area, and another day we'll talk more in detail about the anatomy and guidelines and safety. And it's clear from the Yoshimura work you need multiple small aliquots and multiple depths, as Sid Coleman has taught us. So this is a video that will show you harvesting from the medial thigh. And as you look at this, we pull the VacLock back. Here we're going to infuse first. And in we go with our infusion syringe. And then we harvest, and you see I have no pressure, and I'm at 10 cc's. I'm at the second 10 cc's now, and I'm harvesting from the medial thigh back and forth. The patient is awake, and we have a sterile field below, and we can easily harvest. And then as we go forward, we want to mix, and as we mix, we'll rinse here with saline. You can see a fat aliquot, and we're mixing. And then we will gravity decant after we go through this. And then we pass through the filter, And as we go, we now have the ability here, after we filtered, to push on through into a smaller syringe. And then in this case, we're micronizing with the diamond cut filter back and forth until we have a very nice, even preparation. And this even preparation then allows us to be able to transfer into our 1cc syringes through our female-to-female lure locks. And as we go through these female-to-female lure locks, we're then going to be able to transfer. Let's go forward. We load into a MAF gun, and I'm going to show you this. This is a demonstration of the MAF gun just with saline, and this is 1/60th of a cc, and this just shows you how we can control the sizes very carefully. And in a minute, I'm going to show you how I do it my best effort with a hand. So that's 1/60th of a cc. And here's the sequence again. That's 1/60th. And you click the gun, click, 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 and then we're going to go to 1/90th of a cc, and here in just a second. And as we lay out a grid here, this is 1/90th of a cc. Click, we change to 1/120th of a cc. And they may look like they're a little bit near the same, but as we go through this pattern, you'll see that they get smaller and smaller. And this is saline for the sake of demonstration, 1/50th of a cc. Then we go to 1/180th of a cc, and you can begin to see that each is smaller and smaller and smaller. And then finally, we get to our smallest aliquot here, 1/240th of a cc, and there we are. Now, if I try as best I can with a syringe and hold two hands and try to make smaller and smaller aliquots, I'm just not capable of doing it. So what most people do in fat grafting is they do rapid motion back and forth to move around so that each drop is distributed over a larger area. But I find that using the gun is very precise. I don't need to make the large aggressive motions, and when I don't, then I have less bruising and less tissue trauma. So then we go forward here to the next. Let me go back, click on this. Okay, we're going to go forward. Now this is injecting in the eye with fat, and so here we go. This is the tear trough. We have an awake patient, and you see I don't need to do the traditional rapid back and forth to drop those droplets. This is at 1/240th with the micronized fat, and I can go as gently and as slowly as I want because these little areas of transfer are so small that it's very, very gentle and there's almost no trauma. And so the patient can be wide awake and comfortable. We don't have to worry about aggressive motion or pain control. This patient has only local anesthetic in this area. And so this is how we do it with the tear trough at one, and we pick 1/240th of a cc. Now, after we finish this, we've come out, we've laid down a couple of rows. Here I am trying to do as best as I can with a syringe, the most minimal amount in the temple. And this would be, if you look at our saline example, these may be 1/60th of a cc or more. And while that may be giving us a good clinical level 5 evidence yield, we think that our MAF gun will do better. And so here we are using the transfer at about 1/120th of a cc. And you notice it says north and west, or N and W, at the hub where the purple hub meets the shaft of the base of the gun. You can turn the single hole injection cannula to a different direction, so you can spin that around, injecting up north towards the skin, west in this case would be in one direction or another. And then here we go south, which is deep. There's our patient awake again, the same patient as we did the tear trough on. And in we go here, injecting with structural fat at about 1/60th or 1/90th of a cc. And so you can see there's essentially no bruising. And I'm going to show you some patient examples from early post. And if we go here to forward, this is a close-up of the gun. And I must credit Dr. Sai-Ming Lin. He is the one who developed this gun with his company. And there's the 18 and 16 gauge cannulas for aspirating are for injecting, and then there's the 1 French and the 2.5 millimeters for harvesting, and then the 8 little things that say CC up on the top left, the silver ones, are caps, and then the 2 other ones that are clear are transfer cannulas. And when you go forward to the next slide, you can see here we are having loaded a number of 1 cc syringes and getting ready to place them into the gun itself. And this is what the gun looks like way up close. And so now I'm going to show you what this looks like with fat. And when you see this fat here is doing, again, 1/60th, and then we're going to go forward to 1/90th. Instead of saline, this is fat. And then we go to 1/120th, and you'll see the aliquots of fat are quite small. And we'll keep going to show you here at click, and there we go to 1/120th. Click, click, click for each one of the ratchet type click, stock, click again, and smaller and smaller. And this is very respectful of the Yoshimura limits so that we can get laying down atraumatic, without pressure, without a lot of motion, without a lot of bruising, without a lot of potential pain, so that we can have small, precisely placed aliquots of fat. And so I think of this as a great clinical enhancement. And there are a number of papers in PRS about this. And this is what it looks like when you load it. You take a 1 cc syringe. We preload the syringe. It's about the volume of the hub, and the shaft is a couple of tenths of a cc. And then we can go ahead and inject. And then this is an example. This is pre-op in the tear trough. You can see hollowing in a 45-year-old female. And then 5 days post, there's just a trace of bruising there, just a little bit. And then we go forward, and this is pre and 3 weeks, where you see excellent tear trough correction. What you can also notice, especially in her left lower lid, is the correction of the fine wrinkles, not just the volume restoration, but the fine wrinkles under the eye. Because when you use this SVT here, you can get grafts by flipping the rotation of the open hole. You can inject up close to the surface of the skin, immediately subcutaneous, and then you can also inject deep. And so you see what that looks like. And then this is comparison of the 3-week result on the left with the 1 year. And there's a little bit of loss, but there's slight resorption, but I'm estimating 75–80% volume retention compared to the original. Here's a one injection. Usually we do a touch-up, but this is 1 injection, 1 year. And you can see on the right side at the junction of the lid and the cheek, the volume restoration is significant. We did not do aspiration of the high point on the right, where you can see just a little bit of fat, and we got most correction there. And if you look laterally on the right towards the lateral canthus, you can see there's volume restoration there as well. And immediately under the eyelid, you see volume restoration. And on the left side, you see improvement in the skin quality as well as volume retention throughout. So even with 1 treatment, you can get 75–80% volume retention. And volume retention really is the key, more than number of cells or anything else, when you look at clinical evidence. Now, this is a video that we recorded with Kayla, and she's talking about her experience. You can find this on the company website. And I'm going to, the important point is not her testimonial, although I'm going to play just a little bit of it so you can see her motion, because this was focused on her zygoma and her malar fat. And so if we play this, you'll see her motion. And then what I'm going to do is I'm going to go from her motion, and you see the zygoma and the periorbitum. And then what I'm going to do now is I'm going to go forward to, well, let's talk about adjuvant biologics, PRP exosomes. We don't, at this point, have the IntelliFat process with that in anything other than level 5 evidence, the opinion of some experts. We do think that PRP may help in some circumstances, but I've chosen to focus specifically on IntelliFat isolated because I think it's better. And then we can look at post-op treatment I don't usually use antibiotics because we don't find we need it. Some people hypothesize that increased presence of bacteria, even if it's not clinically detectable, may diminish graft take. So you could potentially use it. We rarely use post-op pain meds. You see how atraumatic the injections are. And we don't know, but we don't use NSAIDs. We do use acetaminophen from time to time if people need it. And we tell them not to shower for 24 hours or so, just to keep chlorine from being right on top of a place where we have an access point. Although we do use Steri-strips, which should give an effective barrier, and we don't immerse in water for 3 days, either in a tub or a swimming pool or something like that. And we think that motion on a fresh graft may delay host ingrowth and graft viability. So we like to keep away from bouncy type sports, inversion, Pilates, yoga, running. Walking we think is okay. We don't like to get the heart rate up and to vasodilate and sweat because we think that may carry bacteria into the microenvironment near the access port. And then if we do gluteal grafting, we certainly don't want sitting in that kind of pressure. And we'd like to wear protective padding on the trunk. This is all personal preference, level 5 evidence or no evidence, just clinical practice. This is a really exciting area, a way to address FDA issues of enzymatic and centrifugation and substantial alteration versus like tissue and like recipient beds, and also convenience, backed by science with colony forming units, backed by engineering and technology with essentially a relatively atraumatic harvesting with the Super G cannula, and then with micronizing filters to provide small aliquots, and then the MAF gun to provide precision in injection and grafting, and this kind of wraps it all together. So thank you very much for your attention. I look forward to meeting many of you when we begin to do in-person teaching sessions again when we transition. Of course, we're in the world of COVID for now, and we look forward to an expanded program. Thank you very much.
Great. Thank you so much, Brian. We really appreciate you sharing your experience and your expertise.
David and Dr. Kenny, thank you so much for that great presentation. I thought it was helpful that you broke it into two components, with David basically laying out the physics theory and the biochemistry of adipose drive biologics. I think it's important for people to understand not only the clinical applications, but the chemical constituents of fat and how the different components create the stem cell niche, if you will, and the cell signals and the scaffolds work together in concert to create the ability to rejuvenate tissue. I think primarily through the release of cytokines, growth factors, and creating an angiogenic effect. But clearly the applications in aesthetics and other areas are very well understood. They're getting more well known, and we see the applications happening in other areas like in orthopedic. So the concept of nano fat or micronized fat, or what I'd like to say is non-enzymatically derived adipose-derived biologics, I think is a very powerful one and very useful. And in many ways, some of the regulatory elements, such as the ability to manipulate or non-manipulate the adipose tissue, which surrounds primarily the use of enzymatic digestion, the collagenase, actually affords better benefit because by holding together the constitution components, i.e. the stem cell niche within the tissue, I think you provide better clinical benefit for the patient. But as always, these are times where things are being understood in clinical practice, the promise is there, and the people see the benefits. So thank you, gentlemen, for taking the time to educate our audience and to provide the resources they need to better understand adipose-derived biologics in their clinical applications in medicine. Thank you.